I thought I'd just start with a bit of a refresher about motor neurone disease, because I'm not sure you know what experience people have had. How many people have looked after someone with motor neurone disease? Quite a few. Okay, do you know what motor neurone disease is? Do you want me to, I'll do a bit of a, just a bit of a skim over. So motor neurone disease is really a group of diseases, so it's not one single disease, and it's where the nerve cells or the motor neurons degenerate and die away, which then results in death of the muscle. So the muscle no longer gets the stimulation from the nerve cells, and generally, and over time they'll weaken and waste away. And so what ends up is people get widespread muscle weakness, wasting, which of course affects, you know, muscles are involved in a lot of the activities that we do, you know, walking, talking, moving, breathing. So over time there's dissemination of muscle wasting, and people are left in a very debilitated sort of way. So there's sort of 5 main categories that we talk about. They're very complex, and even after 20 years of working in motor neurone, I can't always pick which category people have when they come along. But the global type is really the first one that we talk about, and that is your really typical ALS, or amyolateral sclerosis, where there is involvement of both the upper and lower motor neurons. There often begins with wasting in one of the limbs, so it might be the person presents with a foot drop, they might notice that they're having difficulty. Often people will say about using a key, you know, to open a door. That's often where they notice the weakness and the wasting, and then it disseminates to the other limbs, and then eventually in most situations of ALS, people develop speech and swallowing problems. The prognosis from diagnosis is about 3 to 5 years, but often people have had symptoms for, you know, up to 12, 18 months, sometimes 2 years before the actual diagnosis is made. So sometimes that diagnosis is quite reduced. The second global type is probably, I'd say, the second most commonest that we see through the clinic, which is the progressive bulbar palsy, and that mainly involves the upper motor neurons, so those motor neurons that are in the brain stem, and predominantly presents with speech and swallowing difficulties. So often people come along with problems that their partner or family have noticed a change in their speech, they're slurring. You know, often people have been to see ENT specialists because, you know, there's clearly a problem in the throat region. They've often been to the dentist because, you know, they wonder whether it's something to do with their teeth and their tongue. And then eventually they start to have problems with feeding, so they start to cough when they go to eat. And Lisa's going to talk more in detail about the swallowing problems. And this is a bit shorter prognosis, so it's about 2.5 years. And I think mainly because it does involve that speech and swallowing area, and often people get problems with saliva, so they get thick, sticky saliva, dribbling of saliva, and it causes some more problems. And this is more common in females than males. The second type is the flail arm type, and the third is the flail leg type. So this is where the lower motor neurons are affected, and has a slower rate of progression. With the flail arm type is what we call man in the barrel syndrome. So people will lose use of their arms. Often they're quite floppy. They have difficulty with their balance because of, you know, the role our arms play in keeping us balanced. So they come along with this man in the barrel syndrome, where they're sort of walking with great difficulty, trying to maintain their balance. And so over time that can progress, and some of them go on to develop speech and swallowing problems. Sometimes the lower limbs start to become involved, but it's a much slower progression than the global type, the ALS or the pseudobulbar palsy. Progressive muscular atrophy is a much slower variant of motor neurone disease, mainly the lower motor neurons, so the wasting of the arms and legs, and swallowing and speech is often not affected. It's the hardest form of MND to diagnose, and many people diagnosed with PMA in the early stages, so the primary lateral progressive muscular atrophy in the early stages, over time, after 3 or 4 years, it may actually progress on to reclassifying them into having ALS. So it's a very difficult disease to, and often these people can live up to 20 or 30 years. So when you hear about people with motor neurone disease living a long time, this is usually the group we're talking about. And the final group is the primary lateral sclerosis, the PLS, and we still see these people quite commonly through our clinics. We've probably got, of the 75 I think we've got coming through the clinics at the moment, there's probably, I'd say, 6 or 8 that have PLS, which is mainly involves the upper motor neurons. And so they often present like people with ALS, but there's some very specific neurological signs that are absent, and one of them is fasciculations. So generally they don't have the fasciculations, which is the dancing of the muscles that we see commonly with people with motor neurone disease, and that tends to be the main sort of distinguishing factor from my limited neurological knowledge as to the difference between PLS and ALS. I've just got a couple of pictures, I think, just to show you what we're talking about. And you see the wasting of the tongue. Often there's fasciculation, so the movement of the tongue. And if you haven't ever seen fasciculations, you'll never get them when you do. Very interesting. The hands, you can see that the wasting of the, and particularly I think this, what I notice commonly is the wasting of the muscle here. So the hands are very, very wasted. This one's quite severe. Clearly wasting of the hands and the back muscles in this photo. So it is a clinical diagnosis, so it's a diagnosis that's made on clinical signs. So there's no tests that you can go off and have and say this is definitely motor neurone disease. And so, people often are quite frustrated by the time they get to our clinic because of the fact they've often been misdiagnosed, they've often been told they have a number of other conditions, and that can vary from having a stroke to having Parkinson's disease. There's some people that have come along with a dementia diagnosis where it's actually frontotemporal dementia that's secondary to, that occurs in some patients with motor neurone disease. So it can sometimes be over 12 months before a true diagnosis can be made. In Australia, I've just got some statistics there. At least one person dies from M&D and there's another diagnosed each day. So at any given time there's about 1,400 people around Australia. In South Australia we probably would expect to have 80 to 90 people with motor neurone disease at any one time. And as I said earlier, currently there's around 75 of those that come through the motor neurone clinic in one way or another. Some come regularly, some people that we've seen but live rurally and we sort of keep in contact with. So we get a pretty good amount of referrals for the clinic when we look at the number of people that would expect to have motor neurone disease in South Australia. So we'll move on to what I was asked to talk about, which is the clinic. And the aim of the clinic is to address the medical issues for people who actually have a confirmed diagnosis. Even though I say that, we do offer second opinions. So Dr. David Schultz, who now works in the clinic with us, he actually is able to do a second opinion. So a lot of his neurology colleagues will send along patients and ask for him to do another assessment to see that either confirm a suspicion they've had around a diagnosis of motor neurone disease or to exclude the diagnosis of motor neurone disease. And we probably get 2 or 3 patients a year that are sent to the clinic with suspected motor neurone who don't have motor neurone after we've followed them over a period of time, because the progression of the disease is what really confirms the diagnosis. So sometimes we might see people 6 months apart, and if there's little change in that time, then there may be that's not, that can be a cue to say maybe we need to be looking for something else rather than motor neurone, because with motor neurone disease you would expect a deterioration in that sort of time frame. So what we also try to do is make sure that people get timely referrals to other services they require. We don't replace other services, so we're really keen for everybody that has motor neurone disease to be connected to their local services, whether that's through palliative care or through community services generally. You know, our younger clients go to disability SA, our over 65 clients go to domiciliary care in Metro, so that would be your HAC services in country. So we make sure that everyone has local services that can support them, because you know, you can imagine from a distance trying to coordinate the care for that many people would be very difficult. We also like to think that we do have a role in supporting health professionals with providing direct care to people with motor neurone disease. So we're always on the end of the phone and to facilitate best practice. So hopefully that we can keep up to date and informed about what's available for people with motor neurone disease, and we can offer that to our clients. The referrals are made through SAPS, which is the Southern Adelaide Palliative Services, and the main reason for that is because we don't actually have a designated coordinator for motor neurone disease. I mean, this service has evolved without any funding, so it's a service that Peter Allcroft and I started through palliative care, and we've just built it and built it and built it without any, just through goodwill really of other service providers, particularly within the repat hospital. So, you know, the sleep unit, the gastro people, the allied health, rehab, you know, we've got everyone who's just really volunteered their services to help out. I coordinate the service with the other nurse practitioner candidates, so Lisa and Heather Broadbent are the other two candidates in our service, and so we take the referrals, we triage them, we contact the referrer, contact the patient and organise for them to be seen in a clinic. We have the clinics fortnightly on a Thursday afternoon, but the neurologist is currently doing a trial which started in February for 6 months, doing a weekly clinic, and Lisa supports David in that. And we're finding those clinics are full, so I really need to start making sure that that can become a permanent fixture. So we have 3 clinics running concurrently. We call it the MND, which is Peter Allcroft, the MND Reg, which is my clinic that I supervise the registrar. So all our palliative care registrars rotate through this clinic. And the neurologist, who's Dr. David Schultz. Referrals to the neurologist do require a medical referral. His is a Medicarised clinic, but the MND and the MND Reg clinics at this stage are hospital-funded clinics, so they don't require Medicare referral. And as I said before, it's all possible because of the goodwill of repat and the team that's come together to provide the care for these people. And it's just expanding all the time. You'll hear a bit from the day rehab service, which really just came on board the end of last year, but has provided a fantastic service to us. So what happens when people come along to the first appointment is that before they come to the appointment, we actually contact the neurologist who's made the diagnosis. Sometimes he already has posted through a stack of information, including things like their EMG results. So often they have an EMG to look at the muscle, where the muscles are tested. Sometimes they've had a muscle biopsy. In most circumstances, we hope that they've had respiratory function, because that actually tells us whether they're eligible for the riluzole or not, which is the only treatment that we have for MND. But if not, we'll organise them before they come along to the first appointment. We sort of have a general discussion about the lead up to their diagnosis and their reaction when they were told that diagnosis, and we give people the opportunity to ask questions. They have a neuro exam, more extensive exam from David Schultz than from the Peter and the registrar, but it's certainly some neurological examination is required for them to be eligible for the register, which is the Australian MNDR, is the Australian Motor Neurone Disease Register. It's a voluntary register, not like the cancer register where all cases of cancer are automatically registered, but we ask people permission, and I've never had anybody to say no yet. So what that means, each time they come to clinic, we collect information that goes onto a database, and we can then compare our statistics to what's happening around Australia. So it's trying to get a really good cohort of people with motor neurone disease, following them through and finding out, you know, over what period of time things change, what sort of treatments people are having, whether they're having ventilation, pegs inserted, what sort of services they're using in the community. So it's a really good pocket of information that we have access to. And from that clinic, if we need to refer to other services, so if we need to refer to swallowing, disability, carer support, there's a whole range of services that we always spend the next morning after the clinic, you know, Lisa and I are just busily, you know, sending off referrals to where they need to go. So these are all the services within REPAT that do contribute to the clinic. The palliative care service, of course, the swallowing disorders, the respiratory function, the sleep studies unit, the rehab, and we use the physio. We do use the hydro pool too, that's really useful for some of our clients, and the hand clinic and OTs run at REPAT, it's really good for splints for hands. The day rehab services, which is what we tend to refer to now, because then they can get the range of assessments that they need, so they can get OT, physio, speech, clinical psychology, whatever's required. Day rehab will make that assessment. So prosthetics can also be arranged through day rehab now. Rheumatology, and you might say, why we've got rheumatology. We've been doing a study with Dr. Michael Shanahan, who's a rheumatologist, looking at shoulder pain for people with motor neurone disease. Find that a lot of patients get very painful shoulders, and he's got a nerve block procedure, suprascapular nerve block, that he does for people post-stroke and with arthritis. And so we're trialling this for people with motor neurone disease. Very, very useful procedure. Very simple, lasts for about 3 months. So it's just an injection into the suprascapular nerve. So that's, Michael's been very involved with that. And we had some funding to support that project. And OPSA, which is the orthotics, and they're a fantastic service. So a lot of people in the early stages need splinting, foot splints, and those sorts of things. And even neck braces now, they're helping us with. So excellent part of the. So all these services have all come together through goodwill, and I think that's amazing that we've achieved this, really. So the follow-up through the clinic, initially maybe 3 to 4 monthly if they're stable. So we don't need to see people regular, and I think seeing them further apart, actually you can notice changes better than if you see people on a regular basis. Like I said about the equipment needs, if they're under 65 we refer to Disability SA, if they're over 65 we go to Dom Care. Refer to other services needed. We meet monthly, and Graham coordinates that for us. He's fantastic in that. He keeps the minutes, and where we have case discussions. So we actually have put up all of the new referrals that we received in the previous month, and that can range from 2 or 3 to 7 or 8. And we just talk about when they've got appointments, who else within the team they need to see. And we actually have a database that we set up. This is the 2nd year now that we've had the database. We've been able to keep really good statistics around when people have their peg tube, when they start on ventilation, you know, if they're on the register or not. So we've got a really, and when people die, we can actually then have statistics about where people die as well. And last year, over 50% of the MND patients did die at home. So I think that's quite amazing that people are kept at home in the advanced stages. So once we do refer to the palliative care service, and for example, there was a person this morning, I had an email from the Central Palliative Care Service. They've just been referred, this man, and he's been coming to us for the last 2 years. So he's actually been able to be managed without local palliative care input for the last 2 years. And we did talk to him about it at the last clinic appointment, but he wasn't too keen. So sometimes we're seeing people through the clinic for a while before they actually need to get involved with their local palliative care service. And And the preference is for all referrals to RGH providers to come through the clinic. So partly so we can keep track of it on the database, but we're often the people that the referrers are contacting then. So if someone from the community makes a referral to Swelling, they'll then come to us and say, do you know this person? What can you tell us about them? So it's much easier if they come through us, then we can put the referral on. And because a lot of those services are Medicarised, that's really important, so that we can give them a provider number so they can actually bill for those services. So this is how you contact us if you need to make a referral to the clinic. Phone and fax number there. It's myself, Lisa and Heather, and we're all on health email if you need to contact that. So I'm just going to talk about a few other services that have evolved around this. Out in the northern palliative care area, they've set up what they call the Motor Neurone Disease Northern Consult Team, and they did this after consultating with us because they do have their own OT and physio within that team out north. I don't know whether that's going to still be there after the COAG, like everyone's worried about. But anyway, currently they do, and Wendy Jansen, who's a nurse practitioner candidate out there, has an interest in motor neurone disease as well. And this has made our job a lot easier because patients from the northern area that come to our clinic, we can just refer on to Wendy, Pam and Tiu, and then they can actually take over the, organising the local referrals, get the OT assessment organised, organise the equipment and those sorts of things. So this has been a great bonus to us, and they send us a very comprehensive letter after they've gone out and done their assessment, which we can put in the file. So we know that people in the northern part of Adelaide are actually getting really good home support now with a specific team that has an interest, and they work out at the Modbury Palliative Care Service, it's the Northern Service now, so that's their contact details. But again, usually the referrals come to us, we see them in the clinic and then we refer them out. Sometimes they do get a referral and then they'll refer them into us and ask us to see them as well, because they don't have the same range of services that we can offer at REPAT. The other services I was going to mention was the MNDSA, which is the Motor Neurone Disease Association. This is a non-government funded organisation, so it's funded through donations through to the association. They may get a little bit of support, I think, in providing the building where they actually reside, but generally it's a not-for-profit organisation. And their main role is in providing the information, education and counselling to people in South Australia whose lives have been infected in motor neurone disease. So they're sort of the peer support arm of for motor neurone disease. So a lot of people that have motor neurone disease look it up on the internet, and of course they come across the association, and so they've contacted them themselves. So the referrals don't generally come to the association. Generally it's something that people have sought out for themselves. And they do have a registered nurse, John Gilligan, which you may have heard of John if you've sort of had clients. He used to be called the MND support worker, but it's changed to registered nurse. And I think it's because he likes, to keep his registration as a nurse. But so they've changed the title of that service. And John's very helpful. He goes out and actually sees people in the community, and he does a lot of rural visits, so people in the country he can get out to see. So what he's able to offer is meeting with patients and families at the MND Association in their home, or he sometimes will see them in hospital. They have a role in providing information and education services, liaising with agencies, visits to regional areas, and the whole aim is to increase the awareness and knowledge of MND. They do have limited equipment loans, so sometimes if you need a sort of a wheelchair as an interim while you're waiting for someone else to provide that, customised chair, I've often rung the MND Association, asked them whether they have any available. So they have a lot of donated equipment that has come back through the service. And they have helped in funding over time different things like BiPAP machines. So we haven't had any from them for a long time, but at one stage we had 2 or 3 machines that they funded, and they bought us some ion batteries as well, Graham, I think. Yeah, so sometimes when there's a piece of equipment that we need and we can't have difficulty accessing it, I have emailed them and asked them whether they've got any funding to help, which usually they're very, because we don't ask very often, they're usually really helpful. So that's the main sort of function of their role. So they're not a clinical service, they don't have access to any doctors or other health professionals involved in the care of people. So it's really an information support. It's good, if family meetings, if there's family members that don't really understand much about motor neurone disease, want to get more information, really good to get John involved. Some people like to be involved with the association, some people choose not to because they don't want to see other people with motor neurone disease, because sometimes they have meetings where people with motor neurone disease can get together. Some people don't want to know what's ahead and what it's going to look like for them, so they prefer not to. But we do always ask people when they come to the clinic, would you like a referral to the association? And sometimes people will say, no, I'm not ready for that, or no, I'm not interested in that. But I'd say 90% of the time people would say, yes, that would be great. So we let John know. But a lot of our referrals come through John as well. So he'll see people and then refer them through to the clinic. The final sort of useful thing that I thought might be helpful to know about is the MND Care website. It's a really good resource for health and community care professionals involved in motor neurone disease, and there's a lot of different fact sheets and a lot of information there. There's even a little course you can do if you want, online course. So it's a really useful website. I get a sort of a email about once a month from the MND Care, and it sort of updates you with what's new on the site, and I guess I'm trying to keep abreast as much as I can with the research, because people ask when they come to clinic, they want to know what else is available, what's on the horizon. They do their own research on the internet, so we need to try and keep as informed as we can. And this site, often a lot of that information's available on this particular site. So I think that was, my last slide. So that was just a quick run through about the clinic and what we do at REPAT and how we've sort of come about.